Hello, my name is Angela Sass, and today we're going to be talking about restraint use. The purpose of a restraint is to prevent self-harm or harm to others, whether the patient is knowingly creating harm or unknowingly. So if they're confused and their intent is not to self-harm, but removing the medical device such as an IV or dialysis catheter, that would still be reason to potentially restrain a patient. It is not used as a disciplinary action or for staff convenience. There are two types of general restraints. The first is physical. Physical restraints are attached to or next to a person. They cannot be removed easily, and it restricts freedom of movement. They can be applied to different areas of the body. They can be applied to the chest, the waist, the elbow, wrist, hands, or ankle. Typically, this type of restraint confines the patient to a chair or bed. Examples of this are included in the pictures, and I'll go over those in just a second. Another type of physical restraint is when all four bed rails are up. And that's a concern, obviously, for falls, but also it is considered a restraint, and we cannot have all four bed rails up. So when we look at these different pictures, the top left picture with the hand, this is called a mitt, and it does not restrict arm movement, but it does restrict the grasping potential of the hand. So if they were picking at a wound or a dressing, this would eliminate that ability of that pincher reflex and inability to grab something. The one right underneath that is called could be called a wrist restraint or soft limb restraint. It is a Velcro, and the blue part is Velcro, and then it snaps into place. And then you see the strap hanging down. That strap would then be tied to a bed or a chair, something that would then restrict the movement of the arm itself. But you notice that the hand is still functional. In the top right picture is a lap belt. This would keep the patient from essentially getting up. However, these have to be used with caution, because if the patient is able to stand, this can create a dangerous situation. I'll be honest, I had a patient with a lap belt on, and he stood up and had the wheelchair on his back as he was trying to walk. So lap restraints are not always the best option. And so whenever we're deciding what type of restraint we need to use, it's imperative that we make sure it's the safest one for the patient and avoid them if at all possible. In the bottom right-hand picture is a posy vest or jacket restraint. It zips up the back, so it's kind of put on almost like backwards. And then the straps are tied to, usually it is a bed frame. And this just prevents the patient from getting up or turning. So if you had a reason to keep the patient on their back or trying to prevent them from getting up, this would be the type of restraint you would use here. The risk with this type of restraint in particular is that the patient can slide down. So you think about how you take off a shirt. The patient can, if they're with it enough, could try to slide out of it and actually strangulate themselves. So there's significant risk with that type of restraint. The other type of restraint is called a chemical restraint. Chemical restraints are medications used to control behavior or restrict movement. They can also be called sedatives. If a medication is given that is not part of the daily regimen for the patient, for example, patients have anxiety and maybe they take Prozac or Valium once a day to help maintain their anxiety levels. If we're giving additional doses as needed to sedate them, that would be considered a chemical restraint. A daily dose of a sedative or anti-anxiety medication is not considered a restraint. Adverse effects of restraint use. There's two types, physical and psychological. If you think about it, if I were to tie your hands or feet or restrain you from your normal activities or movements, it can create a lot of anxiety, anger, mistrust. These are examples of psychological adverse effects. Other ones that I would consider psychological may be agitation. So even if we have a patient who's agitated, who's trying to remove dressings or medical devices, just restraining them may actually worsen their behavior. Restraint use can also lead to loss of dignity, embarrassment, humiliation, loss of self-respect, reduced social contact. Usually they're isolated when they are restrained. And then the other part of it is physical. So if a patient is fighting the physical restraints, such as those wrist restraints, they can essentially get abrasions underneath those restraints. So physical reactions or adverse effects of restraints include cuts, bruises, possibly fractures. Other risks would include pneumonia, constipation, a decrease or a decline in their physical condition. By limiting movement, we can negatively impact the patient's overall health, and we have to be very careful not to do that. Restraints carry with it many legal issues that, as a nurse or a potential nurse, as a tech or a CNA as you are assisting the nurse has a lot of responsibility in their documentation of restraint use. Number one, you have to have a physician's order, and this is any type of restraint at any point in time. The other thing is that the least restrictive means must be used first. So this includes things like we need to make sure that we have addressed all the patient's needs before we restrain the patient so that they don't have to go to the bathroom, that they're not having pain. If we restrain a patient and we have not gotten a physician's order and not used the least restrictive means first, then it is considered false imprisonment, which can be, a nurse can be charged with this under the law. So this is a significant issue. And lastly, you must have informed consent. And informed consent is that you have, if the patient is not able to consent for themselves, let's say because they're not fully conscious, maybe they're confused, so they can't understand the situation, then we need to notify their family member or their power of attorney. And these things have to happen in order for us to legally use restraints. Alternatives to restraint use. So I mentioned that the least restrictive option must be used first. Examples of alternatives to restraint use are pillows or positioning devices. Pillows can be placed which would prevent the patient possibly from getting out of bed, like if to swing their leg over if they can't get it above a pillow, or to place a pillow so it kind of wedges the patient so they're less inclined to move in that direction. Those would be examples. Positioning devices, I mentioned wedges. And then the environment. It's really important that we look at the environment, and if you have a confused patient who doesn't understand where they are or what's going on, we need to address the environment. So in order to help the patient calm down and remain calm, we want a quiet, usually low-lit environment. So a lot of the times when the patient's at their peak of agitation, we'll turn off a radio or a TV, dim the lights, but not turned off completely, because that would be a safety issue, but dim the lights and create this cool, calm environment. And sometimes that in and of itself can help. We must address any, I'm going to go back to environment for just a second. We also, other options would be to move the patient closer to the nurse's station so that the nurse or staff can keep a closer eye on the patient. For safety, we need to make sure that the patient is as safe as possible. This may include bed, chair, or door alarms, padded hip protectors the patient may wear. If the concern is that they're climbing out of bed and the risk is that they will fall, we want to make sure that should they fall, they are less likely to be significantly injured. So hip pads, floor mats, making sure that the bed is in the lowest position possible. Those would all be things that we can do to hopefully prevent any harm to the patient. And then we need to think about love and belonging. And this is something I don't know that we're always good at, in that we need to address, once a patient is isolated, if they are confused and they don't understand the situation, isolating them in a room all by themselves is probably not the best answer. And so we need to make sure that they have pictures of their family and friends. They may need a companion. Some patients just need somebody to sit by them. And we have to look at those types of things in order to help a patient calm down. So I have given you a brief overview of some of the legal and types of restraints. Now we're going to watch a video. After the video, we'll take a break, and then I will demonstrate appropriate application of these different types of restraints, and we'll practice in lab.
options in therapy to prevent a confused or combative client from self-injury or to reduce risk of injury to others by the client. To complete this exercise, you will need a wheelchair, hospital bed, mannequin or lab partner, wrist restraints, and a posy vest restraint. To apply wrist restraints, wrap the padded portion of the restraint around the wrist or ankle and tighten the strap securely. Be sure to leave a 2-finger gap between the restraint and the client's wrist or ankle. Secure the other end to a movable portion of the bed frame and not to the side rails. This will allow the bed to be repositioned without risking injury to the patient. Restraints must be assessed and documented every 15 minutes, and they are to be removed every 2 hours to provide for range of motion exercises and to check circulation and skin condition. Start by selecting an appropriate size vest restraint. Place the client's arms through the front of the vest. Then pull the zipper up. Ensure that there is adequate space between the vest and the client. Next, pull the vest tails under the armrest and cross tails in back of the chair. Finally, wrap the tails around the kick spur and secure the tails using a half bow knot. Finally, check that the vest is not too tight and that the client is comfortable.
Movable part of the bed, okay? And it just takes practice. And sometimes because I'm so used to doing it, I don't think about it. So let's try and see if I can get it right the first time. First, I got to get it all the way through. Okay, so I'm all the way through. So now I've got it where I want it. I've adjusted it on the wrist of the patient. I've pulled it around. I came around like that. Now, okay, let me go back. I went up, I pulled a loop through. I pulled this through this loop. And I got a feeling that's not right. That doesn't feel right. Oh, yeah, it doesn't feel right. And then I tug on it, and it's tight. I'll pull against it. That's great. And then when I pull my strings, I should be able to quick release. How's that? Did you get it?
So I wanted to show that second video just because she gives a little bit different explanation on how to tie that quick release knot. Some people may call it a half bow knot. Most of the time you're going to see it referred to as a quick release knot. And why don't we take a break at this point in time, and then I have some worksheets to work on so that you can think about what type of restraint is appropriate, and then also identify least restrictive means in a couple given situations, and then we'll discuss it. All right, let's take a break. Thanks.